I hope people aren't too hungry or fatigued, and here I am talking about sleep. So if you were feeling fatigued, now it's going to be worse. But I'll try to go through this as quickly as I can. So I decided to talk about sleep and memory and hallucinations in Parkinson's so that I wouldn't be overlapping with what Sean talked about this morning. And so I wanted to start by talking about poor sleeping or insomnia in Parkinson's. And it's important to say that insomnia is common. An awful lot of us will suffer from it at some stage in our life, but it is more common in people with Parkinson's, and really up to 9 out of 10 people with Parkinson's at some stage will have trouble sleeping. So I wanted to give you some tips when you're going to see your GP or your Parkinson's specialist to think about what the problem is with your sleeping before you say it to them, because that'll really help them know how to help you. So the way I would keep it, I would separate it is, what's the problem? Is the problem falling asleep? And we call that sleep latency. Is it getting to sleep when you first go to bed, or is it staying asleep throughout the night? And then what's keeping you awake? Is it that you're not sleepy, you're just awake? Even though you want to go to sleep, you know you should, you're awake? Or is it that something else like pain or discomfort is keeping you awake? And then is it every night or is it occasional? So I'll go through those a little bit, because how we treat them is really different. And that's how I want you to know a bit about, just saying I don't sleep well is only the first step. So first of all, when we look at problems falling asleep, and again, if we're breaking them down into you're just not sleepy, or you are sleepy, but something else is keeping you awake. When you're just not sleepy, a culprit can be that you've had too much sleep during the day. So we know that Parkinson's affects how sleepy you are by day and by night. It tends to want to make you sleepy during the day and not sleepy at night. So we really need to work to reset our brains when we've Parkinson's. And the way to do that is two things. One is to exercise during the day, and the second is to get natural daylight. And I mean, if the weather is good, it's to get out and exercise outside if possible. But even if the weather is bad, if you have a window that gets the sun, or a conservatory, get as much natural daylight during the day. That tells your brain it's daytime, and then at nighttime, you know it's dark. So we want it to be really bright during the day and dark at night. A lot of people will suffer from daytime drowsiness. And so during the kind of, 3 or 4 in the afternoon, you might start to want to take a nap. That's absolutely fine, but the nap only needs to be 20 minutes or so, half an hour max. If you sleep for an hour or 2 hours during the day, particularly later in the evening, you will not need that sleep at night. So as we get older, we all need less sleep. So in your 50s, you might need 7 or 8 hours sleep a night, but by the time you're in your 70s or 80s, you might only need 6 hours sleep. And as you get older, maybe even 5 hours sleep at night. So if you go to bed at 8 at night, and sometimes people have to because they get helped into bed by someone else who wants to go home afterwards. If you're going into bed at 8 at night and you only need 5 hours sleep, you're going to be awake at 2 or 3 in the morning. So, be realistic about how much time you will need to sleep, and try not to get the sleep during the day, and really, really avoid after tea naps. So these are things that kind of can make people, not be sleepy at night. But another really common thing is side effect of medications. So the medications we give for Parkinson's, the dopamine meds, may keep you awake. So if you're taking them just before you go to bed at night, they may actually be keeping you awake. So we'd often work with people and try the timing, move them a little bit earlier to 7 or 8. Or again, if you're getting a long-acting tablet, a long-acting Cinemet controlled release, going to bed at night, maybe do you definitely need that? The other thing that keeps people awake, so it's hard to get to sleep, is depression and anxiety. So if you're in bed at 11 at night and your mind is racing, or you're thinking of things and you have regrets and there's negative thoughts coming into your head, that can be a sign of depression. And so talk to your GP about that, because again, it might be worth trying an antidepressant. Then the other thing is where you can't get to sleep. It's not you're not tired, but something else is keeping you awake. And so a lot of times that can be tremor or stiffness. And the treatment for that is kind of the opposite of cutting down your dopamine meds at nighttime. It's giving them to you. So, you know, do you need to take an extra dose of, you know, your dopamine just before you go to bed? Do you need to take a long-acting tablet? So again, if you have an idea of what's keeping you awake, then you can work with your doctor to get the medication change. And then obviously it could be something else like pain or other things. So again, and I'll come to pain in a minute. So I want to give you kind of general, what we call sleep hygiene advice. And this is for everyone, so you don't have to have Parkinson's to follow this. So the first is exercise. When you physically exercise, it makes you tireder at night. So no matter how bad your life is, if you're physically wrecked, you will tend to go to sleep. And especially outside, to get the fresh air and get the daylight. Limit your daytime naps, we said. If you're affected by caffeine, don't drink it late in the evening. Some people, it doesn't keep them awake, but a lot of us, if we have tea or coffee at 9 or 10 at night, it'll keep us awake. To avoid nighttime alcohol, it can be really tempting to have a nightcap to help you sleep, but actually we know that only works for 2 or 3 hours and you'll be awake during the night. You get a rebound awakening after alcohol. To kind of keep a regular bedtime routine, and I say here bedroom is for sleep, and I'm going to come out and say it's also for sex. I'm not just saying you should only sleep in your beds, but what you should not be doing is watching television and on a screen. So the light from a screen, and that includes a Kindle for reading if you don't read with books, the light from those can keep you awake. So your bedroom should be a relaxing place. If you do read, it needs to be a nice relaxing book, not a thriller. So you need to get into a regular bedtime routine. And if it's a glass of hot milk, if it's a bath, whatever sends the signal to your brain that it's sleepy time now, like we do with babies, it works for us the exact same. Whereas if you're having a conversation with your partner, if you get stressed over something, if you're checking your email, if you're, online and reading about COVID and getting depressed just before you turn off the light, you're not going to sleep. Also to check your room temperature. So if your room is too warm or too cold, it will affect your sleeping. And blackout blinds, it shouldn't be an issue going to bed at night, except at the end of June when it can be bright very late, but it will affect you in the morning. If your room is bright, it will naturally wake you up. So you need blackout blinds and blackout curtains if you want to sleep later. And then if you're awake and you're comfortable, but you have just been awake for an hour and don't lie there thinking about it, turn on the light and do read, or get up, go to the toilet, walk around and come back later. But the more you lie there trying to get to sleep, the less it'll work for you. So sometimes the thing to do is don't try to sleep, just accept it and get up, and you'll sleep in the next morning if needed. For some people, we go beyond that and we do cognitive behavioral therapy. So that's where a psychologist will work with the person to give them tricks that when you're trying to get to sleep, how can you do that? And then you'll see that I've put medications right down at the very bottom. So these really are a last resort. They come with side effects. They can be addictive. So sometimes we use a particular sleep hormone called melatonin. There's not actually a lot of research evidence for this, but certainly sometimes it does work for people, or sleeping tablets as a last resort, but these will come with side effects. So then if we move on to problems staying asleep, so you've got to sleep fine, but at 3 or 4 in the morning, you're wide awake. And again, if that's your problem, what is it? Is it that you are just awake, or is it that you do want to go back to sleep and you're sleepy, but something is keeping you awake? So again, if you wake at 4 or 5, is it that you've got too much sleep during the day, or you've gone to bed particularly early? Again, are you taking a long-acting dopamine med at night? So that would be the likes of the Cinemet CR, which can keep you awake. Or if you're waking at 5 or 6 in the morning and you're worried and there's a lot of bad thoughts going on in your head, that's a real sign of depression. So again, talk to your GP. So the important thing is, it's not just I wake up at 4, it's why do you wake up? And so I want to talk a little bit about when you're waking up because you're being kept awake by something else. So if it's that you're stiff, you've been in the one position and you're getting really uncomfortable, but you're too stiff to turn over, or your tremor has got bad during the night, we really need to look at increasing your medications. So that can be a long-acting, a controlled release medication going to bed, or it can be a matter of keeping a medication at your bedside locker, and if you wake at 5 in the morning, that's when you take your first tablet of the day. So again, we can definitely help if it's stiffness or tremor. It can be pain, and so I suppose again for yourselves, is the pain kind of arthritis in your hip or knee, which you just need a simple painkiller, or is it cramping, or is it a thing here which I've written down called dystonia? So dystonia is a spasm. It's a spasm that's part of Parkinson's. When the medications wear off, you can get cramping. And a kind of a good clue of this is it does feel like a cramp, and it's typically in your hand or your foot. And sometimes your foot will actually cramp, as in physically you will see it, that your big toe has gone into a funny position, or your foot has kind of gone into like a claw. So I'm going to kind of show you here, you know, with your hand, that your hand is actually clenched, and that's a real sign of dystonia. The muscles have gone into spasm, and that's very treatable with extra Parkinson's meds, or sometimes we can give Botox directly into the muscles and it works really well. So again, you know, can you try to pinpoint, if you've pain, what type of pain is it? And then the other thing is a full bladder. So this is one of the kind of what I would call a paradox of Parkinson's, is Parkinson's generally slows everything down, but for your bladder, your waterworks, it makes you need to go, it speeds it up. So a side effect of Parkinson's is to need to pass water more often, that your bladder gets sensitive and you need to go. So at night, if you're getting up 3 or 4 times at night to go to the toilet, you're awake, you know, an hour after you've been, you're uncomfortable and you need to go again. You know, the first thing is, if you're a man, it could be your prostate. So to get that checked out, because that's so treatable, and that won't be your Parkinson's specialist that does that, that'll be a bladder specialist. For everybody, limit evening drinks. If you drink a lot, cup of tea, big mug of tea before you go to bed, it'll need to come out during the night. There are medications we can give to relax your bladder. Some of those are anticholinergics, so they're the same meds you might be on for tremor. They stop tremor. Again, they can cause confusion and things, so not everyone will tolerate them. Or there's another one, mirabegan, that we use a lot. In extreme cases, we can give someone a spray to take up their nose, which stops them passing urine during the night. And again, if you have a really irritable bladder that you're constantly like getting up every 15 minutes needing to wee, we can actually give you Botox into your bladder. Now, again, it won't be the Parkinson's specialist who will be doing that, it'll be the bladder specialist. But the important thing is to think about it and don't put up with it. There is a lot that can be done for people. So they're kind of not sleeping, insomnia, your sleep is being disturbed. But I want to talk a little bit now about some of the other sleep disorders that you can get with Parkinson's, and you'll have heard of some of these. So the first one is REM, sleep behavior disorder, or RBD, it's sometimes shortened to. And this is really common. Up to half of people with Parkinson's will have it to some degree, and it's slightly more common in men. And it can happen actually before your other Parkinson's symptoms. So sometimes this can be what someone presents with, and then years later we diagnose the Parkinson's. And so what it is, you know, we all go through a phase of sleep which is called REM sleep, or rapid eye movement sleep. And that's when we're dreaming. So you could tell if you looked at somebody while they're dreaming, their eye is actually moving side to side, side to side. And it's our dreaming sleep, and we go through quite a few hours of it during the night. And normally what happens for us is, while we're in this REM sleep, we are paralyzed. So we jump off a building in our sleep, we draw out and we punch somebody in our sleep, but we don't actually do it in the bed. However, in Parkinson's, and again, this is another paradox, when we're talking about Parkinson's slowing everything and stopping movement, here's a weird thing, it allows you to move during your dreams. So in your dream, when you draw out and you punch the robber in the face, you may actually do it to your partner in the bed. So people act out their dreams. So in the morning, you can wake up and your bed is really disturbed. The bedside lamp is knocked over, you're sore, you realize you've hit your arm during the night, or the person in the bed with you says, I'm not staying in this bed anymore, you whacked me during the night. So you act out your dreams. And then when you wake up, sometimes those dreams can be really vivid. So you wake up and in your dream, you had a fight with someone in the house. And in the morning, you kind of say, did that actually happen or not? So it's not like sleepwalking where someone can't remember. You actually can remember those dreams really well. And there's an awful lot we can do to help this REM sleep disturbance. So, simple things are to make the bedroom safer. So maybe moving into a big double bed and taking away lamps and things that are within reaching distance. If you haven't been on treatment for Parkinson's, the meds can sometimes actually make this better, but for some people they make it worse, and we may need to stop the long-acting tablet at night. There's a particular treatment called clonazepam, which works really well for a lot of people. So it's a benzodiazepine, kind of like a sleeping tablet, but it particularly works on your sleep cycle. And sometimes antidepressants can work. So it kind of depends how bad it is. Sometimes it's just a matter of knowing about it, and it explains why the bedclothes are particularly pulled all over the place. But again, if you want to stay in a bed with somebody and they can't stay in the bed with you because you keep hitting them, then maybe medications are the thing for you. So again, it's hard sometimes to know what's happening to you, but someone who sees you asleep can tell you. The other kind of movement problems that you can have at night with Parkinson's is restless leg syndrome. So a lot of you will have heard of this. It's very common. Again, you don't have to have Parkinson's to have it. It's where you're sitting, particularly in the evenings or coming to bedtime, you're sitting down, you've been sitting down maybe for an hour or two watching TV, and the next thing your legs are getting uncomfortable and they're maybe itchy. You feel like there's something crawling in them. I actually have restless legs. For me, it feels like my legs are too big. They've kind of swollen or something. And the only way you can get relief is to move them. So you kick about, you have to get up and walk, and that takes it away. There's a lot of things you can do. I mean, the obvious thing is to get up and move. So we don't want to do really vigorous exercise just before you go to bed, because that can wake you up. But, you can walk around slowly. So again, not to go into bed hours before you're ready to go to sleep, because then the restless legs will come out in the bed. So if you suffer from them, to kind of make sure you're walking around just before you get into bed, because it usually takes a while for the restless legs to come out. If you have low iron levels, treating with iron can help. If you're, if that's not the case, your dopaminergic meds will help. So Cinemet will help, but often we actually use dopamine agonists. So things like Mirapexin, these can help really well. Or we can use Gabapentin. So Gabapentin is an anti-seizure tablet, but some of you will know of it, like there's lots of forms like Lyrica and things that they're used for kind of any kind of nerve pain. So, restless legs is a nerve problem. The nerves in your legs get sensitive. So this medication can work very well, but it doesn't suit everyone. Sometimes it can make you a bit drowsy or a bit confused. So again, think about, is that why you can't get to sleep at night, is because your legs are uncomfortable in the bed. The other thing I just mentioned is periodic limb jerk. So that's another movement disorder that's very related to Parkinson's, where during the middle of the night you just jerk. So it's not like the REM sleep disturbance where you're kicking out in random ways. It's always your legs start to jerk or something like that. And we diagnose that with the sleep study. So just to kind of mention that. So apart from kind of movement problems, the other common problem in Parkinson's at night is sleep apnea. So this basically is where during periods of the night you stop breathing. And it's really common. Sleep apnea is common anyway, and particularly men are more likely to get it, and kind of in your 40s and 50s, and if you're overweight. And so what you know is the person who's affected snores at night, and then they're snoring, and then they kind of wake up. And the person themselves might notice that when they wake up, they kind of feel a gasping or a choking sensation. And then they might be drowsy during the day, because if you've woken up like this multiple times at night, it can make you drowsy. Now, it's important to say a lot of people snore. So it's not just snoring doesn't mean you've sleep apnea. It's one of the signs, but really you have to have the kind of multiple wakings and the daytime drowsiness. So about 1 in 5 people with Parkinson's suffer from sleep apnea, but it's much more common with the atypical types of Parkinson's, like multiple system atrophy, because that your breathing is in your brainstem, and that's where multiple system atrophy particularly affects. So a lot of times when we first are diagnosing someone with Parkinson's, we'll particularly ask, do you have snoring and things? And if we've any concern, we'll send you for a sleep study where you get hooked up to a brain monitor and a breathing kind of monitor at night, where we check your oxygen. And the way we diagnose it is at various times during the night, your oxygen goes really low, and then you wake up, because that's what wakes you, is your oxygen levels drop and your body wakes you up to take a breath. And there's loads of ways to treat sleep apnea, and I'm not going to talk about it a lot because that's like a different talk. But you know, some simple things are avoiding alcohol at night, because that will make it worse. When you go into a deep alcohol-related sleep, everything gets a bit floppy. So kind of how sleep apnea works is, while you breathe out, your kind of airways collapse a little bit. So alcohol relaxes your muscles and you are more likely to snore. And I think anyone who has had a few pints and gone to bed will definitely snore. My own husband, I can definitely a culprit there. So alcohol brings on snoring, and in its extreme form, it brings on sleep apnea. You can use pillows to stay off your back, because sometimes that helps, or you can bring up the head of the bed. Losing weight definitely can help, even though an awful lot of people with Parkinson's don't need to lose weight. Sometimes chin straps and things like that will keep your chin in the right position, because that kind of lifts up everything from sagging down in your neck. And then you might need a breathing mask or a CPAP device. So that's continuous positive airway pressure. So as you breathe out, you're breathing out against a current of air, and it keeps all the airways open. And again, this was something had come out in our research, is that people having to pay for this, whereas this should be available to anyone who needs it, because it's a medical treatment you need. But unless your treating doctor knows that, they won't advise you how to fill out the forms. So I talked a good bit as I went on there about daytime fatigue and drowsiness. And I suppose these are different things. Fatigue is where you are physically tired. You need to sit down. You know, you'd like to make a cup of tea, but just the thoughts of getting up off the couch to make it is too much. Whereas drowsiness is where you feel you need to sleep. But they do go together a lot. And both of them are common as Parkinson's goes on. So, and for both of them, you know, simple things you can do yourself is to get fresh air, to get natural daylight, to change your position. So get up and walk about when you're starting to feel a bit as if you might nod off, and exercise. So people think if you're fatigued, you shouldn't exercise because you'll use up your energy, but actually it's the opposite. The more you exercise, the less you'll be fatigued. Do plan short naps, but set an alarm. Try not to sleep more than 20 minutes or half an hour max. And just the other thing is that sometimes drowsiness can be caused by medications. So it can be worth working with your doctor to change them around or reduce the dose at certain times. It's not always, though. I've definitely had people where we've really stopped a particular dose and yet they're still as drowsy as ever. So it's not always the medications. And the other thing is, sometimes if you're very fatigued and you're inclined to fall off asleep, it actually can be a sign of being off or low blood pressure. So if you're, you know, say you've had a big heavy meal and your blood pressure drops after it, you'll actually start to go off asleep, but it's due to low blood pressure. So again, is your clinic checking that out for you if you're drowsy, making sure it's not low blood pressure. And then we can treat with medications. If someone has an awful lot of daytime drowsiness and we've tried everything else, you can take a drug called Modafinil, which is a stimulant, a mild stimulant. It doesn't suit everyone. People who've taken it have said to me, it's kind of like having 6 or 7 cups of coffee. So sometimes people feel a bit jittery and a bit on edge with it, but then it does suit other people really well. So sometimes we try it, but not everyone is suitable for it. So I'm going to move on from sleep because I am conscious of not taking up all your time. I'm going to move on to cognitive impairment now and memory problems. And I thought a lot about this when I'm talking to you. I don't want to be depressing anyone. Like I think it's hard to hear that as well as having Parkinson's, you might be at risk of having dementia, but equally, it's an important thing to know. And also there's things you can do to help your brain stay healthy. And if you don't know that, you can't do anything about it. So part of Parkinson's is to have slow thoughts. So when you're off and your body is slow, your thinking can also be slow. There's nothing wrong with it, but it's just a bit slower than normal. And I'd say this because it's really important if you're coming to a clinic or you're in hospital and someone comes to have a really important conversation with you and you're not at your best. You're finding it hard to focus, your thinking is slow, to say to them, listen, I need to take my medications and can you come back to me in an hour? Because you could be in a much better brain situation in an hour's time. And I didn't know this years ago. I didn't know that Parkinson's affected slowness of thought until I twigged that there was people, and I was meeting them at different times, particularly in hospital, before and after medications, and their thinking was really different. So, if your body is off, your brain may be a bit off as well. So we know that 70 to 80% of people with Parkinson's will have some cognitive impairment after about 8 years, and about 1 in 3 will eventually develop dementia. And we call this Parkinson's disease dementia. It's not Alzheimer's, it's a totally different protein. It's the Parkinson's protein. But it's important to say that, look at this, 70% of people with Parkinson's will never get dementia. So I don't want to worry you, but it's something to think about. And we know that depression kind of goes hand in hand with low mood and falls and having an awful lot of fluctuations and having hallucinations, but they are different, and I'll talk about hallucinations in a second. So again, not to scare you, but it's handy to know if you are at more risk of developing dementia, is the older you are, and that's for all of us. Dementia is a disease of aging, because as your brain ages, you lose, naturally you lose brain cells. And so if you are developing dementia, it gets worse as you get older. If you're older being diagnosed with Parkinson's, so if you were diagnosed with Parkinson's in your 40s, and that's a terrible thing, don't be worried that you're going to develop dementia in your 60s or 70s. You may not at all. Whereas if you're diagnosed with Parkinson's in your 70s and you're alive in your 90s, you are at higher risk. So the older you are, the higher your risk of dementia, because your brain is naturally, it's aging. If you have more severe motor findings, so the worse your Parkinson's is, the more your risk for dementia is, because that's just showing that the protein has spread more in your brain. Again, if you've mood problems, that can be a link. We can particularly kind of see that you can have verbal fluency problems. So this would be, we might say, can you name as many words starting with the letter S in a minute as you can think of? And that's a good clue for us that you might be at risk of developing dementia. Another thing would be kind of problems paying attention and things. I'll show you this actually in a memory test in a minute, or hallucinations. Part of the reason that we kind of always keep an eye out is that if you are developing dementia, it's important to know it in terms of thinking about your priorities over the next few years. If you were going to go on a world cruise and you were kind of thinking, well, my Parkinson's motor-wise is good at the moment, I can wait a few years, maybe this changes your mind and maybe it makes you think, well, maybe I should go earlier. Or things like, have you got a will? How secure is your house and things like that. These are all things that you need to think about before you develop dementia. So, while I don't want to overly worry people, you can't stick your head in the sand and then you develop dementia and then it's too late to do some of the things you would have liked to have done. So the important thing to say about Parkinson's dementia is it's very different to Alzheimer's. So in Alzheimer's dementia, which is the common dementia that most people think of when they think of dementia, you have forgotten. You have lost the memory. You didn't store it in your brain properly. It's gone. In Parkinson's, the memory is there, but the problem is getting it out. So I'm going to give you an example. Someone rings and you pick up the phone and it was Anne. We'll say you're a man and it was Anne rang to talk to your wife. And your wife comes home from wherever she was and you say, oh, someone rang for you. It was one of your friends. I can't remember who it was. If your wife said to you, oh, was it Mary? Was it my sister? Was it Anne? You'll say, oh, it was Anne. Because you hadn't forgotten, but you needed the clue, you needed the prompt to bring out the memory. So it is important to know that it's not that you've forgotten, it just gets harder to think of it. Or actually you might find you can't think at all. Your wife comes in the door, you're a blank who it was, and 5 minutes later you're doing something else and you think, oh, I remember, it was Anne. So to remember that the memory isn't gone, it's just harder to get it out. Parkinson's also really affects your planning and sequencing. So if you were in the middle of doing a task and someone distracts you with something else, you may really find it hard to do. So you might have been adding up numbers in your head for something, and then someone asks you a question and it's gone. You have to start all again. So this is really important to know that, you know, at times, if you're being put under pressure to perform a mental task, whatever it is you have to do, you know, make sure you're in a quiet room and that people don't disturb you. And again, if you're due to take your medications and you're not feeling well, leave the task to later. So pick your good time of the day when you're not sleepy and your brain is working well. You know, for a lot of people, that's about mid-morning when you're particularly good, and do your your bank details then. So yeah, don't let yourself be distracted, and, you know, give yourself the time you need. So I wanted to show you a memory test that we do. This is the MOCA, Montreal Cognitive Assessment. And it's really important that if you do get your memory tested as a person with Parkinson's, it's a test like this is done, and not some other tests like, you might have heard of the MMSE, or the Mini Mental State Examination. If you have Parkinson's, you'll probably fly the MMSE. It'll miss the problems you have. This one works well because it's testing. Here it's sequencing. You have to go up in kind of numbers and letters. You have to copy out shapes. You have to draw a clock, and we ask you to put in a particular time. You have to name animals. These are the ones you'll struggle with. Whereas when we get down to the bottom, the orientation questions like what year is it, what day is it, you won't have problems here. Whereas a person with Alzheimer's, this is where they'll struggle. So it is important that you know this is why you're being given this particular test. It's also important to say you could Google this and you could practice this test. Don't ever do that. You don't do yourself any favor by practicing to get a better score. Your memory is as it is, and it's important your doctor knows that. So, you know, because I think it would be tempting to say, I'm going to practice this and do really well if I ever get it. So when I see people at my clinic and we think that maybe between us, we think that they're starting to have a little bit of memory trouble, this is the kind of test that we do every year or two to map it out. And then we see at what stage might someone need some medications. So there are medications from Parkinson's disease, dementia, but actually the most important thing is to stop medications you don't need to be on. So you might have been on an anticholinergic like Chemidrin or something like that for your tremor, and actually we may stop that because that's like an anti-memory tablet. It's a fantastic drug for tremor, but it can affect memory. And we might stop some other drugs like Azilect. We might change your Stalevo back to plain Sinemet. If you were on Symmetrol again for dyskinesias, we might stop that. We might stop other tablets like Lyrica or other painkillers. So the first course for us is taking away any unnecessary medications or reducing dose. Then there is treatments for dementia that they're very like treatments we use for Alzheimer's, and they can work. And these are the two recommended ones. And then some people, unfortunately, when you take these, it can make your tremor worse. Because tremor and memory, the treatments for those are like opposite each other. So sometimes when you start the treatments, it will make your tremor worse and you may have to go on memantine. There isn't as much evidence for that, but it won't affect tremor. So again, you don't need to know this. Your doctor should know this. But again, make sure you're seeing somebody who is familiar with these and who's confident. And if they're not, then you could be seen at a memory clinic where they'll definitely be expert in this. The other thing I wanted to talk to you about is your brain health. So again, 70% of people with Parkinson's will never develop dementia, and that's really good news. Here's some of the things you can do to increase your chance of being in the 70%. It's never your fault if you develop dementia. A lot of it is your kind of destiny, but so don't ever feel I did something wrong if I developed dementia. But there are things we know statistically reduce your chance. So make sure your blood pressure isn't too high. Now I know for most of us it's low blood pressure is the problem, but if it is high blood pressure damages your blood vessels. It can cause small strokes. It can damage the brain. Smoking absolutely damages the brain. You should not be smoking. Alcohol is a brain poison. And so I'm not saying you shouldn't have a drink, but you shouldn't be drinking to excess. So, you know, there are kind of recommended limits. It's like 18 units for men, which is about 9 pints a week, you know, and it's less for women. You should be drinking occasionally in moderation. If you drink heavily, you're poisoning your brain, and that's going to just make everything worse. The Mediterranean diet. So some of you will have heard of this, but here's kind of typically what it is. It's fresh fruit and veg. You'll see these are really brightly coloured. The more coloured a fruit or a vegetable is, the more antioxidants it has. So it's a diet that is very largely based on fruit and veg and oily fish. And so oily fish is things like salmon or mackerel, not cod or shellfish or plaice. So the white fish aren't oily. Another way to think of it is if it gives you indigestion, it was probably oily fish. So, and some people can't take oily fish because of that, but you can take a supplement. But if you can tolerate it, the fresh fish is better. You should be having this about twice a week. There's not so much red meat in this diet, and there's not processed foods. But of course, you don't want to be a saint either. But if you can, start to bring in more fruit and veg, more olive oil instead of butter, more oily fish, fantastic start. I have hearing here, and I think this might be a surprise to a lot of you, that hearing loss is a big risk for dementia of any kind. Because if you're not hearing conversations, you're not paying attention to what the person's saying, and you're kind of not exercising your brain. So everyone over 50 is entitled to free, not over 50, everyone with a medical card is entitled to free hearing checks. And if people around you think you might have a problem with your hearing, as a person with Parkinson's, get it checked out, because it will affect your risk of having dementia in the future. And if you need a hearing aid, and it can be very challenging to work a hearing aid with Parkinson's if you have a tremor, but to persevere and wear your hearing aid if you need it. Cholesterol is important for all of us, but as you get older, it becomes less important. So your own doctor will advise you if you have high cholesterol, and if so, should it be treated? And two really important things is challenging your brain. So doing crosswords, Sudoku, playing bridge, dancing, which you've got to follow steps, learning a new instrument, learning a new language, challenging your brain. Your brain is a muscle, and if you build up a healthy, big brain with lots of blood vessels and big, fat, juicy brain cells, even as you have Parkinson's and some brain cells are getting damaged, the other ones are in really good shape and they'll take over. So the bigger and the better the blood supply your brain has, the slower your Parkinson's will affect you. And stay socially active. So we know that meeting people, having to remember things about them. Oh, there's Tony. Is it Tony's niece moved out to Japan recently? What was her name again? Having to make those social memories is actually really good exercise for your brain. So you don't have to be doing crosswords if you don't like them, but try to remember things about people and meet people, because that exercises your brain. I'm nearly finished now, Tony, because I know people are getting tired. I have just 2 slides. Will I keep going for these? So I wanted to talk about hallucinations, and often people think hallucinations means dementia, and they are related, but they're very different things. So hallucination is where you experience something that's not real, and they can be hearing something or seeing something or feeling it. And we know that, a lot of people with Parkinson's will suffer hallucinations, but they nearly always are visual. So you're seeing something that you think may not really be there. And they can be fully formed hallucinations, that there's somebody sitting on your couch who you don't know, or it can be just a feeling that there's someone else in the room, and you feel if you turned around quickly enough, you could catch them, and yet you never can. No matter how quickly you turn, you can never quite see them, but you feel they're there. Or sometimes it might be feeling someone has just passed by you. But as I said, it varies. And a lot of times, I suppose the first thing is to say, hallucinations are normal in Parkinson's. A third of people will have them. And so don't ever be afraid to tell your doctor you have them. It's a normal part of Parkinson's, just like sleep problems or swallowing problems, so it's something that, we should all be talking about matter-of-factly. And the important thing is it can be a side effect of your medications, and particularly the dopamine agonists. So again, your Mirapexin, I don't want to keep picking that, there's lots of them, but it tends not to be such a problem with Cinemet. And so often what we try to do is cut down medications and simplify them. The same as I said for dementia, it's the same process. It's trying to get back, and often we end up going back a lot to just plain Cinemet because it's cleaner. Now again, if you have a deep brain stimulator, you may not need as much medications. If you're on a pump, particularly if you were on Duodopa, then you may not, that may actually help your hallucinations as well, because you're getting a constant low dose. We look at all of the medications, Lyrica, painkillers, antidepressants that can cause memory problems, and we stop those. I suppose a few things to say. Depending on what your hallucinations are, you may not be safe to drive. If you think that there's somebody suddenly after sitting into the passenger seat with you, or there's someone outside the car, you may crash your car looking at them. So depending on the situations you get your hallucinations, it's something to think about. There are medical treatments for hallucinations. So if we pull down medications as much as we can, and the hallucinations are bothering you, so you don't always need to get medication. If your hallucination is that there's a dog in the room next door and it's not bothering you, it may just be something that you live with. But if you need treatment, we used to give antipsychotics, and we know that they actually can really make your Parkinson's worse. So we tend to use these only if the hallucinations are really severe or distressing. So, you know, if you're having nasty hallucinations, like someone is chopping off the heads of babies or something, then you will need treatment. But these really can affect your Parkinson's. So there's two we use. Quetiapine is a really mild one. And clozapine is one that you have to have kind of weekly blood tests with. So we only use that if you really need it. But another thing we can do is to give memory tablets. And sometimes the memory tablets also work for hallucinations. And so they're kind of our first line treatment. So again, I don't expect you to remember any of this. I just want you to know there are medications, but a lot of the times your doctor will be working with you to cut down some of your tablets, and also to see maybe these hallucinations are something that you just live with. And the very, very last slide, I just wanted to mention other quirky things that happen in Parkinson's that we don't talk about enough. These are things you may not notice as a person with Parkinson's. It may be your family member actually notices them, but I think it's good to know about them. So Parkinson's, and particularly the medications for Parkinson's, can affect how you behave. So sometimes people will start to have what we call impulse control disorders, where you start to kind of become reckless. Maybe you start gambling, you start driving recklessly, you start to really shop an awful lot. Not that we're all doing that with COVID, the online shopping, but you take it to extreme, or you become really interested in sex, really pestering someone else for sex. That can be a side effect, particularly of the medications. And so if we don't talk about it, and if people, when they come to clinics, don't say it to people, we can't look at the medications. The other common enough thing, well, it's not that it's common, it's just that it's linked to Parkinson's, is morbid jealousy, where you become convinced your partner's having an affair. Or excessive, what we call excessive hobbyism. So, you know, you always like to play a musical instrument, but now you're playing it 10 hours a day and you're driving everyone else mad. That's actually can be, again, a side effect of the Parkinson's meds. Or the other is sometimes that you can kind of get a bit addicted to your tablets. So you start to pop your tablet whenever you're not feeling well. And again, you know, I don't think we talk about these enough. I think in clinics, we're often so busy, we forget to ask. So I'm kind of drawing them to your attention for you to make sure you tell your GP or tell your specialist that, you know, the person you're living with who has Parkinson's is acting a bit differently to normal, and that'll trigger us to talk to you a bit more. So just to summarize, there's an awful lot you can do to self-help, to sleep well, and to keep your brain healthy. And I hope I've given you some useful hints there. Don't ever be afraid to report a funny symptom or funny behaviour. It's often part of the Parkinson's or a side effect of medications, which means we can deal with it. There's nothing you could tell us that we haven't heard before or that we'll be embarrassed by. Exercise is really good for your brain health and for good sleep. And I think if you took one thing home from all of today's talks, it's to get out and exercise. Diet is also important. And again, it's fresh fruit and veg and oily fish. And to keep an eye on your hearing. You may not have been thinking of that, but keep an eye on your hearing, keep an eye on your own memory. And then if you're anyway worried, ask your doctor to do a memory test, and to keep an eye on your blood pressure. We don't want it too low because that's bad for your brain, and we don't want it too high either. So that's all I was going to say there. And I hope I haven't put you all off to sleep.
No.
Lack of food.
Suzanne, brilliant. Thank you very much indeed.